So a very good morning to all of you. So we are very happy that All India Ophthalmic Society has arranged this Glaucoma Speciality Day, and for the first time in the history of the AIOS, we are having a speciality symposium by the World Glaucoma Association, and all credit for this academic feast goes to Professor Dr. Namrata Sharma, the Chairman Scientific Committee of the All India Ophthalmic Society. So before we start this MIGS Symposium of WGA, I would like to invite Professor Namrata Sharma to please address the gathering.
Thank you, Tanuj. And at the outset, I would like to thank the entire leadership of World Glaucoma Association, who's with us here today, and they have traveled from far and wide. And I would like to thank my scientific committee members as well as Dr. Tanuj Dada for organizing this wonderful glaucoma feast. I think Tanuj was always skeptical whether we are going to give a good hall or not, but I think this is a beautiful hall. It could not have been better than this. And thank you, scientific committee members as well, Dr. Amit Purwal and Dr. J.S. Bhalla for coordinating the glaucoma part. But thank you, Tanuj, for getting all the international luminaries on board during the World Glaucoma Week in our country at Kolkata. We are truly, truly privileged. Thank you so much.
Thank you, Dr. Namrata. So we'll start with the session. Thank you. So the World Glaucoma Association is a unique glaucoma network and representing over 90 countries and all glaucoma societies worldwide, with the sole mission of eliminating glaucoma-related disability worldwide. And I would ask you, all of you, to register yourself in this free website, WGA.1. And this is one website where you have a plethora of information available for all glaucoma trainees. So when you register in the society and you set up an account which is totally free of cost, you get access to a lot of very high-level instruction courses with audio-visual modules. These include basic courses such as gonioscopy, intraocular pressure, perimetry, optic nerve evaluation, and then 2 sets of advanced courses which cover the OCT, management of pediatric glaucoma, angle closure glaucoma. And there is a new educational tool which has been introduced, that is the fundamental questions in glaucoma. These are short 4 to 5 minute lectures by top experts in the field of glaucoma, which cover each aspect of glaucoma, right from the history, examination, diagnosis, therapy, and include all the surgical videos of the current techniques used in glaucoma surgery. In addition, the benefits of becoming a member of the WGA include you get this IGR, which is a fantastic resource of peer-reviewed articles. The abstracts are given with the expert commentary. And of course, you have access to the Journal of Glaucoma, which is the official journal of the World Glaucoma Association. And the most important event that is hosted by the World Glaucoma Association is the World Glaucoma Congress. And the next one is the 11th one, which is going to be there in Honolulu, Hawaii, USA, from June 25 to 28, 2025. And those who would like to attend, I urge you that you have to apply for the US visa well in time, because sometimes the waiting dates go up to 1 year. So do not miss this fabulous event. And today we have a really wonderful faculty who are the pioneers and the leaders of glaucoma surgery worldwide. And we are going to have insights into minimally invasive glaucoma surgery. Coupled with that, we have some very young, promising talent from India who are starting the MIGS in our country, training surgeons. So this is going to be a mix and match of the top surgeons across the globe and our Indian talent, and it promises to be a wonderful symposium on minimally invasive glaucoma surgery. So without any delay, I would like to invite the first speaker, Dr. Prasanna Venkatesh Ramesh, to please speak on intraoperative gonioscopy and training. And there are some of the speakers are going to use laptops, so I would request, if you have a laptop, the speaker should be ready on the second podium. And the Q&A interactive session we are going to have after all the talks are finished, so please keep your questions ready. So thank you very much, and over to you, Prasanna.
Thank you, sir, for this opportunity. And WGC has always been special to me. I learned mix in WGC Melbourne, and now it's an upcoming journey. So I'm going to talk on from of my publication in IGO 2023 on how I started and the direct gonioscopes. So gonioscopes, direct gonioscope was something that just resurfaced, and the principle you can see that the images were erect and it was not inverted or lateralized, and the total internal reflection was one that we actually had to break. And Copi's lens, when we have the Richardson Schaeffer's lens, Huskin-Barken's lens, Swan-Jacobs, and the top direct lens and the Leyden lens. Let us not go into theory, let us have a more practical discussion-based one. So we have the recent advances. The compatible microscope is very important for a direct gonioscopy. Microscopes that have come after 2000 have this tilting facility which helps it, and that is the algorithm that we wanted to see, the preoperative, the intraoperative, and the post-op, and preoperative anesthesia. So I always prefer a peribulbar block to start with so that it helps you in building your confidence, then followed by the microscope tilting. So let us have a more video-based one. So once the phacoemulsification, if you are combining it, you can see that this is me passing the microscope away, and the microscope tilt can be done at 35 degree towards the operating surgeon, and then it is passed to the surgeon. Now the eyepiece tilt has to be tilted in such a way that you will be able to get it back to the position where it's comfortable to your neck. And I use this pencil marking so that you don't depend on your assistant every time when you do. So before tilt and after tilt, you can see that you made a pencil marking of 30 to 35 degree. It serves a huge amount of help, and this is very important, the lift up of the eyepiece. It's called the eyepiece stooping, and the inclinable binocular tube is very important in the microscope that you are going to use. Another smartphone application that you can also use is this app called the angle meter, and also you can get the marking done. And I always believe the pencil marking is something the way forward. It really works well for me. And again, tilting the patient's head another 30-35 degree away, it really gives you a total cumulative 80 degree. You can see this is the final position that I am showing. And what is the gonio lens that you can select? I am personally using no financial disclosure, the TVG lens, the Glaucos, and the Catina. We have the iPrism SX, iPrism S, the Volk lens. But this is one lens I really found well working in my hands, which had this Thorn stabilization ring one. I'll just show this video here. You can see this Thorn or the Thornton stabilization ring. It helps us in docking the patient's eye much better. Once you use the coupling fluid and place the lens, you're able to dock. And see this video, my dear friends. With simple HPMC, you can just start by practicing with this docking lens, the left and right maneuvers that you can get, and extensive more than 180 degrees you'll be able to navigate with this docking kind of feature. I think in the beginning stages it really worked well. We have the Catina, we have the Catina hands-free lens, ocular secure, and Oculus gonio ready. And this is a recommended position. One that we need to keep in mind is the receding back. You can see the angulation, it's more obtuse rather than acute that you can see me here, which is more obtuse. You need to recede back when you tilt the microscope. And the hand positioning, the app positioning in this video, you can see the left hand is always what I emphasize on, because that's a direct gonioscopy one, and you can see it has to rest very gently on the zygoma. That's very, very important. And full illumination. So in cataract, we don't give full illumination, but you can see here in this video of mine, I increase it to 100% illumination after you finish your cataract. Again, the corneal incision should be slightly anterior compared to your phaco, and you can always have this beautiful overlocking. The superior nasal and the inferior nasal has to be accessed so that you will be able to have more amount of maneuvering. That is very important, just like the overlocking movement that you get. In intracameral, you can go for soft shell technique, and this is one particular thing that works well for me. I use a Helon GV Pro followed by some amount of HPMC on the top, which works well, and no financial disclosure. Again, this is an unedited video. Once you are ready to do the direct gonioscopy, keep a hand on the left hand. Once you place the lens, there is a centrifugal distribution of blood. You can see that the field is very blood. When I place the lens, you can see that the blood distributes centrifugally, and never move your left hand now. Then use the zoom. Zoom in. I have made an animation there. Left foot pedal is main. Zoom in. Now use the fine focus. You can see the animation on top. Now I am fine focusing. The left hand is as stable as possible. Now you want to identify the main wound so that you can enter. So again zoom out. Don't move your left hand again. Now use use the instrument, whatever you're going to do, whichever mix that you're going to do, you can go in and then do a very beautiful surgery, whatever goniotomy that you're going to talk, the next speakers will be covering on. And initially what I started feeling is, to start off, just take the Sinskey hook to just dab and touch and feel the trabecular meshwork. It makes a hell lot of difference to get oriented in 3D. And these are something that you need to avoid. Reflection from scratches in the initial days are very, very troublesome, which you need to avoid. Again, excessive pressure. If you're going to give more pressure on your left hand, what is happening? You're seeing the corneal striae, which is actually causing lot of distortion and avoiding, which you're not able to see. Again, more pressure in the initial days. You can see how the Schlemm's canal is collapsing in one of my cases, where I'm going to give more pressure. Again, another thing is managing blood reflex. This is one of my cases of iStent inject W. When you are placing it, you can see that there are a lot of blood reflexes that is happening. So again, technique to clear the blood. This is a video that I made to sync the left hand and the right hand side. There are a lot of blood that is happening between the lens and the cornea. So I'm again repeating the same mistake. But then I tell my assistant to put the fluid or the corneal, the saline on the lens, and then you clear it, and then again go back and you'll be able to get a beautiful feel. Again, when you do complex surgeries like a suture gad, lot of blood, you'll have to put lot of copious viscoelastics, clear it, and then get the surgery done. So for a successful procedure. So hands-free technique, again, that is possible with time. You'll be able to master it. I'm just winding off. And always indirect gonioscopy can also be combined along with direct gonioscopy for advanced mixed surgeries, where you can always tilt the patient's head back and check whether you are in the right plane by doing an indirect gonioscope along with direct gonioscope on the table. So training, there are many things for training. There are this simile eyes that you have for KDB and for the glaucos, no financial disclosure. But when you train in these eyes, even drop stents, which you can actually encounter in practice, like this case of mine when there was a drop stent, you can always go back and you can reassess, pick it, and then place it again. So these are things that will really help you. And we have our own publication in the metaverse with the headsets that we have innovated, where you can actually code your fingers in the three-dimensional novel metaverse, where this headsets will really help you to have a portable simulator. So this is the first mix simulator that we made, where you can see that with this innovation of mine, you can practice mix in the place where you are, because in cadaveric eyes and in goat eyes, you don't get to practice angle surgery, where the dexterity can be improved and the hand-eye coordination can be improved, and presenting to you the first mix simulator which we evaluated and also published. So thank you once again, sir, for giving me this opportunity. We have also extensively published on visualizing the angle dynamics, which is due for publication. Thank you, sir. Thank you for the opportunity.
Thank you, Dr. Prasanna. That was really an inspiring presentation. And our next speaker is Steven Mansberger. He is the Director of the Glaucoma Services at Portland, Oregon, and has additional Masters in Public Health. He's a well-known international speaker, clinician, and researcher. And today he has been going to speak on a very important topic, which MIGS to choose for which patient. So over to you, Steve.
Your name? Oh, Steve Mansberger. Has that been refreshed? Because I loaded it. I loaded it at 11.
Our next speaker will be Dr. Panda. So when the presentation finishes, I would request all speakers to be ready on the other podium so that we can have enough time for discussion after the presentations.
File is not working. We can go to somebody else and I can go at the end, maybe. There it goes. Okay. Great. Sorry about my slides not getting loaded here, but now they're ready. So I'm going to talk a little bit about which MIGS you should choose. And the minimally invasive glaucoma procedures have been around at least a decade. And it's interesting that we have lots of results about them, but we still don't know how they work and which ones to choose, et cetera. So I'm going to try to help a little bit with these questions. These are my conflicts of interest. I think the biggest conflict I have is that I'm a middle adopter of technology. I like to let all these other experts try these things out, see what works and what doesn't work, and then I like to jump in after that. So I like to get the iPhone like a couple generations back, and then I get the iPhones, that kind of stuff. So, and I've been experienced with almost all of the MIGs. So how do you choose between cataract or cataract plus? the mechanism of IOP lowering with these surgeries, and which MIGS procedure, which plus do you do for which patient. So this is just a little snapshot of a whole bunch of different procedures that we do. Some of these are no longer available. Like this was a gold called a Solex shunt that was supposed to be titratable. We have the iStent here, which there's newer versions now than the trabectome, which some people use, some people don't, but has really gone out of favor as well. So this is a paper that we published several years ago, just looking at cataract surgery alone and what it does with pressure with patients with ocular hypertension. And what you can see here is the pressure goes down, and it goes down for a long time, more than 3 years. So cataract surgery is pretty effective in just lowering pressure by itself. Then we published a paper, I think 2 years ago now, looking at the medication group of the OATs. So this would be a group that might be more similar to our glaucoma patients in that they're on glaucoma medications. And what you can see here with pressure, there's an initial lowering of the pressure with the cataract surgery, but then it stays below stays below the baseline pressure, but it's not as much of a result as before. So but what you do see in this group is a large drop in medications. So basically, these studies in ocular hypertension show that it does lower pressure over a long period of time, and it decreases medication burden. So our MIGS plus, our cataract plus, or the MIGS what are they adding? They're hopefully adding a little bit more to this lowering in pressure and decrease in medication use. So there's lots of information about why cataract surgery lowers pressure, and we're not exactly sure why. We're hoping that some of the imaging technologies coming out, we might be able to better explain cataract surgery effects as well as the MIGS effects. But there's this classic is it a biologic process that lowers the pressure where you kind of stimulate the cells in the trabecular meshwork to work better. Same with the MIGS, and whether they just by taking the cataract out, stretching on the zonule that holds the bag, whether that pulls open the trabecular meshwork and allows the pressure to go down. So trabectome was you can see it here, but it's just it's just like a goniotomy with an irrigation port and a cautery. And this was a paper published back several years ago by the best surgeons in the United States doing this. And what they had about an 80% failure on trabectome, which is pretty similar to gonioscopy. And 70% of them required further surgery. But the interesting thing about that is also the opposite, is we had 20% of those that actually did really well and never needed another surgery. And that's the hard thing about these MIGS, is we don't know who is in that 20%. This is a famous paper by Randy Craven that was the pivotal study for the iStent. And what you can see here, there was really no statistical differences between iStent plus cataract versus cataract alone at 2 years. There's only about a 9% difference in pressure. And medication use, you can see, is just a 0.2 difference. So pretty similar to cataract surgery alone with the iStent, at least in this group. This is a paper that we published from Devers in Portland, Oregon. And what we did is we wanted to look at cataract alone versus cataract with iStent versus cataract and goniotomy. And what you can see here on this slide here on the left is this is the cataract alone in the dotted line. You can see that basically what the MIGS did most effectively was prevent an IOP spike the first day after surgery. And we know that IOP spikes occur between 40 and 60% of glaucoma patients. Is that enough to have a MIGS on your patient just because of this IOP spike? Again, we might have that 20% of people that really do well with it. We don't know who. And then they had a little bit of a modest effect on medication use over time. The Hydra stent is one of the newer stents. It recently released their Horizon study where they showed that they had pretty good IOP lowering. And what this is that it's made of nitinol, which is kind of like a flexible metal, and you place it into Schlemm's canal. It's about 2 to 3 clock hours. And so it exposes more of the trabecular meshwork than a goniotomy or an eye stent. And what they found was that that the results were not that much difference between the groups. There was 0.4 medicines in the microstent group versus 0.8 in the cataract alone. But there was a higher proportion of people that were medication-free and less risk of incisional glaucoma surgery and decreased visual field loss, which was a unique finding. It was the first MIGS to show that it decreased visual field loss in comparison to cataract surgery. And this is just the IOP results and the medication results. So, and then GAT, what we're going to hear a little bit more about with that one. The nice thing about that one is it's really, the cost is very minimal. iStent cost about $2,000 US dollars. The Hydrus cost about $2,400 to $2,500 US dollars. The GAT you can do with a Prolene suture, I think it's $3. So this is kind of my go-to if I really need more lowering, is using the GAT. The interesting thing about the papers that show the success of GAT, they almost all use pilocarpine. And that's something we don't typically do preoperatively. It's not a common medicine that we use in the United States. So the question is whether pilocarpine is driving a little bit of the effectivity of this GAT procedure. And then finally, just remember the Goldman equation. Episcleral venous pressure is 8 to 12, so the best lowering you're going to get is something above that with your MIGS procedure, and that's what they've been shown. And then this is a paper by a fellow who was also at our institution named Rosenquist, and what he showed was if you take out from 0 clock hours to every single clock hour removing trabecular meshwork, the resistance is not going to really change above about 4 clock hours. So that's what I typically do with my GAT procedures. I just do 6 clock hours, leave the other 6 clock hours alone, and you have a decreased risk of bleeding and things like that. And again, this is a paper from our group looking at the risk of IOP spikes, and it's somewhere about 40% of our glaucoma patients. So again, this is where the discussion I go with the patient is if this will help prevent an IOP spike. It might be a small change in medicine list, maybe a small change in intraocular pressure. And that's one of the most important things, just giving that expectation to your patients. The last thing is about cost. I have an MPH in biostats and epi, and it's something that I think about all the time is that medical care is getting more and more expensive, and just the cost in iStent in 100 patients is about $268,000. If it got rid of one medicine, that's a saving. That would cost about $8,600. So the excess cost of this in 100 patients is about $260,000. So it's really unclear about whether the cost benefit of these treatments are. And then the last thing I just want to go over real quickly is just what my considerations. Is it early disease? If they're on a blood thinner, using a procedure, a MIGS that removes tissue, increases the risk of bleeding and having a hyphema and needing a secondary procedure. At least in the U.S., they might have a high copay, and so I'm just kind of wondering about these extra MIGS and what they might cost out of pocket, and whether the patient is able and willing to use medicines. They say, I don't mind my medicines, then I sometimes will just go with a cataract alone and not worry about it. If they need a cataract and they've got a fixation, or they've got visual field loss close to fixation, then I'll sometimes choose a MIGS just to prevent that IOP spike. But we're not exactly sure how IOP spikes affect long-term glaucoma. So in summary, cataract surgery is the most minimally invasive glaucoma surgery and lowers IOP in most patients. MIGS surgeries have mild effects on IOP and medication burden when compared to cataract alone. And our unmet need is a patient-specific, titratable, pressure-sensitive surgery where we can put it in like a pacemaker. We say, hey, we want their pressure to be 12, and that's what it does. So thank you.
Thanks, Stephen, for giving a very realistic outcomes of MIGS and how effective is cataract surgery. So our next speaker is none other than Professor Surinder Pandav, who heads the Department of Ophthalmology at the Advanced Eye Center, PGI Chandigarh, and has been previously the Glaucoma Society of India president. And he'll be talking about the bent ab internal needle goniectomy, which is one of the most cost-effective surgeries for our population. So over to you, Dr. Pandav, please.
Thank you, Tanuj, and thank you, AIOS, for this opportunity. I have no financial interest in any of the devices that I'm going to mention. MIGs have been around for some time now, and I think they are going to stay because the scoring point for them is that their safety profile is very good, and they also produce significant lowering of IOP. Generally done for mild to moderate glaucoma, and where you also have a cataract, or if you want to reduce the number of medications, I think they are a good option. Now, bank procedure is easily available, so this is essentially the outline of my talk. Any surgical procedure should be easy to do, should be accessible, effective in lowering IOP. The cost is a big consideration, and of course, it has to be safe. So if you look at the bank procedure, it can be done by any glaucoma surgeon, actually. It does need training, no doubt about that. There's a bit of a learning curve. But procedure, once learned, it is not very difficult to perform. All you need is, most of the surgeons, they have the basic setup, and assuming a good microscope, as you learned in the first talk. And all you need is a direct gonioscope and some practice in looking at the angles in the operating room. And once that is done, additional equipment is just a needle, 25G needle, which doesn't cost you anything and is very easily available to most of us. And of course, with a little practice, important thing is to have a good visualization of the angle, use high magnification, and also bright illumination and the proper positioning of the patient. And once these elements are taken care of, the rest of the procedure is not very difficult, and you could actually, the bent needle can go into the Schlemm's canal and strip it off. The only complication that most often happens is a hyphema, which is quite common, and it's not to worry actually, because it also indicates that we are somewhere in the vicinity of the drainage channels, and which actually is in a way is a good thing. Now, if you look at the efficacy point of view, the outcome of the bang in primary open glaucoma is about 20% IOP reduction you can expect, and also a reduction of reduction in one anti-glaucoma medicine. So there's a significant decrease in IOP. Though we don't expect IOP decrease like we expect in trabeculectomy, but I think because it's the early and moderate disease where this much effect could be good enough. And to get some IOP, significant IOP lowering efficacy, at least 30 degrees gonioectomy is required. But by and large, most of it be stripped up, 4 to 6 clock hours, which gives us the optimal results. And if you look at the bank procedure with KVD, which is very similar to actually bank, it also produces a significant lowering of the IOP. And also, if you compare the efficacy of the bank procedure with other MIGs, I think it is quite comparable, and we should expect around 20% IOP reduction, a little over 20% IOP reduction in, say, 73% of the patient with open angular glaucoma, so which is a good results for early to moderate disease. This is our own experience. This is actually the early experience when we started doing bank procedure, and initial 30 eyes. They were all kind of glaucoma patients, not necessarily POAG, but we had a mixed kind of, and they were all controlled with multiple drugs. So if you look at the IOP in the upper graph, there was a significant reduction from, say, about 15.5 to about 12. But more importantly, we saw a marked reduction in the number of anti-glaucoma medicines that we were using in the post-operative period. So that's, in that sense, is quite a satisfying results. Now, for this procedure to be effective, it is very important that procedure is done in a place where you have the collector channels, and this is very important for eye stent as well as the hydrus. The bank scores a little bit because you are removing a large part of the temporal meshwork, and the probability of having a collector channel increases when you are doing a large stripping of the temporal meshwork. So I think bank has an advantage here in terms of the location, of the collector channels over eye stent. And the cost has all been mentioned. So the cost analysis is actually quite difficult to do, but I think this is basically from the U.S. data. So if you look at the TRAV within the first year of surgery, the trabeculectomy scores quite reasonable, but the eye stent is very expensive. SLT actually the lowest, because SLT can also reduce intraocular pressure to similar extent as we are seeing with in the MIG procedures. among the MIG procedure in this study, the trabectome, which is again somewhat similar to bang in a way, was found to be the most cost-effective in terms of cost reduction per millimeters of mercury IOP reduction. But if you go beyond first year, then I think the initial cost of the procedure is high, and if you take that away, then the IOP reduction cost is like 12 to 61 millimeters of mercury pressure. Again, the lower side is basically for the trabeculectomy group, and the higher side is for the bang or bang-like the MIG procedures. So there's a big economic advantage in doing MIG procedures, and this is the commentary which is published recently in IGO, and I think again they tried to convert figures for our consumption that in terms of INR, and if you see the trabeculectomy remains a reasonable option. Glaucoma drainage devices are a little expensive, but if you go to the eye stent is the most expensive procedure, I think, if you look at the IOP, the cost of IOP reduction of 1 millimeter of mercury. So this is a very expensive procedure. And trabectome, again, is higher. The suture gap is very cheap. And the bang procedure, of course, whatever IOP reduction you get is kind of more or less free of cost. So I think the bang score is very high if you look at the economy of the whole, the glaucoma surgery. The safety profile is very good and is, I would say, excellent. The only problem is hyphema that mostly we see on table, which is not very much of a consequence if you have a better patient selection and taken care of the anticoagulants that the patient is taking. Hyphema can occur in the post-operative period, but I think, generally speaking, it's not much of a concern. Other complications could be the damage to the lens or, damage to the iris or iodialysis, but they are rare, and I think its profile is very good. So to summarize, bang is available everywhere, easy to use, and if you look at the other options, they are really very expensive. So if you are thinking in terms of starting bang, MIG surgery, I think it's better to start with the bang. Thank you very much.
Thank you, Dr. Pandav. So you gave a very nice message. All of us should start MIGS with a bang. And our next speaker is from Arvind Eye Hospital, Tirunelveli, and Dr. Devendra Maheshwari. He has published the first study from India on the use of the Tanita microhook trabeculotomy, which is another non-expensive method for MIGS. So we like to hear his experience about microhook trabeculotomy in patients of primary open-angle glaucoma. Is it going to take some time? So I think some audiovisual issue with the PPT, so we can invite the next speaker, Dr. Vanita Pathakre, who will be speaking on excisional goniotomy with KDB. So Vanita is one of the pioneering MIGS surgeons, and she's the first one who has practiced all these MIGS surgery, a renowned surgeon from Center for Sight, Hyderabad. So we look forward to all her MIGS talks, and today she'll be sharing her experience on the KDB. So over to you, Vanita.
Thank you so much. Very good afternoon. I hope it's afternoon now yet. Good morning, sorry, to all our international guests as well as national ones. I've been asked to speak on, it's not moving forward. It's not moving forward. Oh, okay. Thank you. I've been asked to speak on excisional goniotomy, which I feel should actually be called a goniectomy, and I will show you what I mean by that. So minimally invasive procedures are preferred throughout the body. Every specialty wants to do it because of the faster operating time, high safety profile, rapid recovery, and improved quality of life. This is the most important thing, patient-centric. Cost notwithstanding, patients do prefer it. And open surgery is still a fallback, especially in advanced cases. So why should glaucoma be deprived of its innovations? Its innovations have been in the form of MIGS, which, like anti-glaucoma medications, utilize natural physiological pathways, like the trabecular meshwork, suprachoroidal space, and ciliary body, avoiding the unnatural drainage that we do in trabeculectomy. For this, you need a good view of the angle because it's mostly ab-internal. So a new skill must be acquired. So there are various classifications. I'm not going to go through that. But MIGs currently available in India are not that many. And I forgot to include Tanito microhook. We do have a few that are TM or Schlemm's canal based, and of course we have cycloablative procedures, which I do quite a lot. So there are many ways to skin the same cat, which is the trabecular meshwork. You can use a needle, you just heard. You can use Tanito microhook, which actually Devan is going to talk about, but unfortunately his presentation is after mine. You have the Cyan, you have the trabectome, you have the Kahoot dual blade, and that is what I'm going to talk to you about today. It was launched in the US in 2015 and is designed to achieve near complete removal of the trabecular meshwork with minimal surrounding tissue damage. It has a sharp tip with a taper. It has a ramp which stretches the trabecular meshwork and dual blades which cut it precisely, and a heel that fits within the Schlemm's canal, which is just about 230 microns in meridional diameter. So let's have a look at this one. This was a phakic eye, angle recession, young patient, 45 pressure, 5 drugs. You have to be careful in such eyes. You should not be damaging the ciliary body band, and remove only the trabecular meshwork. A little regurgitation is always welcome. And you see with this, such a precise cut of the trabecular meshwork is achievable. Yet another patient, this is actually angle closure. You're not seeing the trabecular meshwork very clearly because there are lots of goniosynechiae in the background. But as and when I cut, you can see it widening, and you can see unroofing of the Schlemm's canal in a very precise fashion. Again, I remove the trabecular meshwork, and you will shortly see it on a sponge. And therefore, for me, this is goniectomy, not an otomy. Post-operatively, nice picture of unroofed Schlemm's canal. So there are many publications which have talked about KDB in various different etiology, and there has been a review as well which has shown fairly favorable results. But I'm a firm believer of presenting my own experience, and here it is. When I have combined it with phaco in mild to moderate POAG eyes, I have got over 30% reduction in pressure, over 80% reduction in medication, over 90% surgical success, 0 reoperation rate, and no serious sight-threatening complications. The complications that I have faced are transient hyphema. I have not seen a level so far, but transient IOP spike in the first week may actually happen much more commonly. I've seen pigment deposition. You can see there, white arrow shows you that. You can have goniosynechiae or PAS formation, and so far, I've not had to do any redo surgery. I'd like to share with you a case study of a 66-year-old male, PACG, with cataract on 5 drugs in the right eye, 5 drugs in the left eye, 4 in the right eye, and this is how he presented to me. Obviously, IOP is important. He was totally uncontrolled and had early cataract, like I said, and gonioscopy was open only 270 degrees. His disc was very cupped in the left eye, and the visual field was corresponding to that, with fixation being involved. The right eye field was absolutely fine. So I stopped all his medication. Diamox was commenced, and this is how he looked after I discontinued all the anti-glaucoma medication. And as a reminder, you have the pre-photos there as well. So what did I do? I actually did not just KDB, but I combined it with the ECP in his left eye. And this was done in August 2023. I feel that this combination is synergistic in fashion. Inflow and outflow are taken care of. And 6 months post-op, his vision is 6/6, uncorrected, white and quiet eye, pressure of 11, but I have kept him on some medications because it's very advanced, glaucoma, and only once daily application. Before I did his left eye, I actually did his right eye with ECP, and he's without any medication in that eye. So I'd like to share with you the results of combining KDB with ECP. Now, what you're seeing there first is phaco KDB in mild to moderates. So a pressure of 19 reduced to 12.9, 13 maybe, and 2 drugs reduced, right? And when I combined KDB with ECP in advanced glaucoma, again, fairly good results. I see a reduction in low teens. I see a reduction in medication. And what? I avoid any sight-threatening complications. There was certainly no loss of vision. So the key points I'd like to share with you right now is that there are a limited number of MIGs available in India, but unlike TRAB and tubes, they utilize natural pathways. KDB is quite efficacious in reducing IOP and eliminates AGM to quite an extent. Very safe, and MIGs preserves the conjunctivas. You can still do a TRAB, and is easily combined with cataract surgery. It's safe in advanced glaucoma too. Thank you very much for a patient hearing.
Thank you, Vanita, for your excellent presentation and very instructive case studies. So now we go back to Dr. Devendra Maheshwari, who will be covering microhook trabeculotomy.
Hello. Is what? Yeah. So I think there's no financial disclosure. I think already had been seen the MIS become a trend. I think it's a need of era. Right now, these are the various MIS options available for the various MIS are there. And you look at the trend toward the surgery worldwide, MIS is trending. And really down the line, 5 years, everyone will do the MIS as a first choice of surgery. Whatever the MIS you want to decide, depend upon the economic condition, patient, how much patient follow-up can come for your follow-up. There's various factors involved. What kind of MIS do you want? So look for the device-based and TM-based MIS. I think India, most of the MIS prevalent is TM-based. I think because the cost is a big concern in country like India, where you see the cost, really whooping cost of eye stent and KDB, while the GAT and Bang became due in a few dollars. So coming to the goniotomy is long history. Otto Warken did in 1936. Then problem with the goniotomy, really the inability to lift the tubercular mesh wall, while in the newer goniotomies, elevate and excise the tubercular mesh wall, assess the collector channel. So the multiple studies has shown goniotomy has either incise or strip definitely reduce the IOP. So what are the challenges in India? Why we did not become popular in India? Because the cost, one of the big concern. If we go the point-wise, like the GAT really have the steep learning curve. It produces wonderful IOP control. We can get the IOP 10 at 12, but again, learning curve and hyphema. Post of hyphema, we can't avoid. Even whatever you do, it may be happen in some certain cases. KDB quite expensive. Per case, we can do the 1 or 2 case by spending 45,000 rupees. I still have good safety profile, but again, look for the cost is the problem. Bang really is good safety profile, easy, economic, but again, I feel it really is a novice surgeon's hand and needle is little some risky. Though I countered my previous Surendra sir, and he told really is very easy, but really the needle in the eye when you don't have any MIS experience, have to think about it. So coming to the Tanito micro hook, it is a very efficacious, easy to learn, economic, has a very good safety profile. Why? So what we do in ab-internal trabeculectomy, we clip the trabecular meshwork, inner wall of Slim's canal under direct visualization, thus reducing the outflow. Indication, like as usual, already all MIGS, we have contraindication, ocular inflammation, neovascular glaucoma, aphakic glaucoma, and advanced glaucoma. And beauty of this procedure, apart from the gate, this is the only procedure where we can incise or reach the trabecular meshwork 180 to 240 degree. So you can see, apart from the gate. And this is the instrument, is simple Sinski kind of instrument. So they have 3 kind of instrument coming. One is a straight, one is a right angle, the third one is a left angle. So why it is good? Because you see the devices, what we have for MIGS, and see this micro hook. Micro hook like a Sinski hook. I think every surgeon familiar with Sinski. So I think add information, learning curve, it's much easier than any other instrument, because we all do the cataract surgery, all use the Sinski. So really, it's just like a Sinski instrument I saw in my surgical video. So I get the opportunity to meet the inventor of micro hook, Masaki Tanito, and I'll see this video, how easy procedure it is this. I think already my previous speaker has seen how to visualize the angle. So just dog the lens with high viscoelastic, what you're using, a density viscoelastic. And this is the side port, no need to create an additional incision also. Just what the side port you made for the phaco, throw the side port, take the hook, and just cleave the trabecular meshwork. And just one right hand side, then take the left hand side, go another, go to the supranasal. Similar way, you can say the nice, beautiful, surrounded by the back wall of the Slim's canal. And similar way, you can turn to the opposite side and you can reach to the temporal angle. First nasal angle, then you go to the temporal angle. Apart from that, the beauty of this procedure, certain situation you see like the complex situation where any incisional surgery is really, I think, difficult, whether trap or tube, really is you have to do multiple surgery, then you can do MIGS in such cases. And this is the procedure. Oh, sorry. Yeah. Sorry. So after finishing the phacoemulsification, though it's complex case, we have to use the CTR, hooks, everything. And after that, you can see this, again, you're going to the micro hook, and you can incise the nasal angle. Just you do the 3 to 4 o'clock over into the both side, and you can get the excellent IP control, similar to the KDB or Bang or any other available procedure right now we are having. Though we are learning slowly, so some colleague in the China, they are doing a lot of angle closure cases with the Tanito hook. Even the Tanito hook is much safer than angle closure in compared to GAD, Bang, KDB, irrespective of any procedure you have right now for stopping or tripping the trabecular meshwork. Why? Because this instrument is not very sharp. It's a blunt end. So you can see after doing phacoemulsification, you can do the goniosynostosis, and this hook can also be used for the goniosynostosis as the use curved, so it gives a very good view. And after doing the goniosynostosis, deepen the chamber. After deepening the chamber, again take the hook. So this again take the hook through the main boot or side port, whatever you are having, and just you have to cleave the trabecular meshwork. And you can do right hand side, left hand side, and really if you need extra IP control, you can go for the 220 to 240 degree also. So we did the one study, it's called first randomized controlled trial on the microhook. We published in Ophthalmology Glaucoma. In this study, we took the 144 patients, divided into two groups. One group went for phaco with microlot, second is a phacoemulsification. You can see the good IP control throughout the 12-month of period, 26 to 12 mmHg at 1 year. When you compare the IP control between phaco group and lot group, you can see the marked difference into the phaco versus the lot group. So, just I take the 2 minutes more. So just compare the complications. There's no complications. The only high beam is complication like any other procedures. And look at the survival curve. You compare the both phaco versus microlot. You can say microlot have the good IP control throughout the 1 year. Now look at the various studies has shown the microlot produce good IP control and there is a reduction of the anti-glaucoma medication. When this microhook is compared with the other devices like KDB, there is no significant difference. Then coming to microhook, when one eye is put the microhook, one eye put the eye stent, and it shows the microhook has a good IP reduction in compared to the microhook. So this again the time track study where they compare the microhook with the trabectome, and really the microhook has no inferior to the trabectome. Really, there's some complication, hypema and IP spike is part and parcel of any MIGS surgery. So the microhook tornado is efficacious and safe procedure to mild and moderate glaucoma. Is a viable MIGS addition to the glaucoma surgery, especially in low and middle socioeconomic country. Thank you for kind listening.
Thank you, Dr. Devendra, for talking to us about microhook trabeculotomy and how it can be beneficial. Our next speaker is Dr. Swati, who is senior faculty at Erevant Eye Hospital, and she'll be talking about should we rip the entire canal using GAT.
Good morning, everybody. Thank you, Tanuj sir and AIOC for giving me this opportunity. And I really feel overwhelmed that I am sharing the stage with so many stalwarts in glaucoma. So I am supposed to talk on should we rip the entire canal? And this is all the debate which is going around me with my colleagues and everybody, that whether 180 is enough or 360 is enough. So I'll be not just talking about GAD, but I'll be talking about other 180 degrees trabeculotomies as well. I have no financial disclosures. So we all know that the juxtacanalular trabecular meshwork is the site of greatest resistance to outflow, and the canal-based procedures aim to bypass this resistance either by stenting or by de-roofing the canal. And this can achieve the IOB similar to the episcleral venous pressure as already told by Dr. Stephen. So either you can stent by doing iStent G1, G2, D3, or you can put a high-risk microstent. You can do trabecular meshwork incision by GAT or excision by KDB, bag, and tenato hook. So this is a video where I'm showing GAT. I'm using 50 proline suture, which has been blunted at the tip using a low-temperature cautery. And after making an initial goniotomy, I'm threading the suture into the Schlemm's canal. By gentle strokes using the MST forceps, I'm advancing the suture inside the Schlemm's canal. When the suture is in the right place, you don't feel much of a resistance. And then when the suture appears at the opposite side, at the initial goniotomy, we re-grasp it above the suture which is placed, introduced first, and then we zoom out and then take off the lens. Then using McPherson's forceps, we just pull the suture from outside, creating an internal de-roofing of the Schlemm's canal. So this 360 degrees GAT is achievable, and initially when I started GAT, it was difficult for me. It used to get stuck at 180, but then I used to thread it from other side, and I used to get 360. So this is the largest follow-up, 4-year surgical follow-up, and it's a retrospective study of 59 eyes, and the mean IOP reduction they got was 45%, and the number of medications that got reduced was from 3.2 to 2.3, and the cumulative failure was 59.3. 28 eyes underwent resurgery, and 10 eyes had inadequate IP control. Now, if you see at G1 and G2, they bypass the trabecular meshwork, and then this is a study which has got the longest follow-up of 7 years, and it has an absolute mean reduction of 4.8, that is 5 millimeters of mercury reduction, and 12% underwent glaucoma surgery again. This is another study which has got an 8-year follow-up with 62 eyes and IOP reduced by only 26%, and this is only when they were placing 2 stents, G1, that is eye stent which has got a L-shaped, this is the first generation eye stent, so instead of placing 1, they placed 2 and saw the reduction in pressure, it was 26, mean medication decreased by 17.9%. And there is a study which says that more implants, more IOP reduction. So in this study, they said that with every implant, extra implant, that is eye stent inject, they got additional pressure reduction. What about Hydrus? Hydrus is not yet approved in India, but as Dr. Stevenson showed in his video, yes. So it's a 5-year study, 5-year-long horizon trial that has come up, and it has got an IOP reduction of 49.5%, and medication-free patients were 66%. KDB, as you can see, as described by Dr. Vanita Pathak, that it's a handheld knife device to engage and stretch the trabecular meshwork and then excise it. And it can be done like for almost all the cases like which have got where you have good angle visualization, and it just houses into the Schramm's canal, and then you can just rip off the roof. This is another study which has got the outcomes of KDB, retrospective study, 3 years follow-up, and they say that success at 36 months was 52.5%. So in the end, I will be summarizing all these studies together in tables, but this is like eye stent inject versus Kahook dual blade. Their IOP reduction was 46% in the phaco eye stent group as compared to 51% in the phaco KDB group. So it's like almost comparable. And then last is the bang, which is the least expensive method, and the first to start with, I would also say, if you don't have a tenito, then you should start with bang. So you bend the needle and then you introduce into the trabecular meshwork, the Schramm's canal, and then you go either, if you are right-handed person, you can go in a forehand stroke and towards your left-hand side, and if you are a left-handed person, if you feel more comfortable, you can go a forehand stroke with the left hand towards the right-hand side. So this is another study by Dr. Arsham Shebani, where they found more than 20% reduction was found in 73% of the eyes, and the decrease in AGM was 73%. So in a recent study which was presented at American Glaucoma Society by Dr. Aik Ahmed group, they compared standalone 360 degrees trabeculotomy using a suture, that is a suture gad, versus a 180 degrees trabeculotomy using an eye track or an Omni device. And it's a prospective study where they had 9 participating centers and 263 consecutive eyes were taken. And this is the current literature which shows that, okay, sometimes 360 trabeculotomy is comparable. They say they are superior, 360 is superior to 180, but then what they also concluded that the 360-degree trabeculotomy without phacoemulsification demonstrates higher surgical success and IOP lowering as compared to 180 degrees trabeculotomy, although the 360-degree group had more high FEMA as compared to the 180-degree, which is logical also. So if you see compare all these data, you see IOP reduction by GAT is 45, whereas by bang in one group is 73%, and by KDB is 52, and Hydrus is 49. So what am I achieving by ripping off the 360-degree trabecular meshwork? AGM reduction also highest with bang as per the study by Dr. Shebani, and then followed by Hydrus and KDB. And these are not opening up 360 degrees. So as you can see, the GAT has got 360, but eye stent generation 1 caters to only 30%. Eye stent injects caters to 4 clock hours or 60 degrees. Then Hydrus is 90, KDB is 120, and bang is also 120 degrees. But all these, we are opening the Schramm's canal, but what comparable results we are getting in terms of IOP in even better with the lesser on 180 degrees trabeculotomies. And look at the cost here, and you can see that bang costs just 100 rupees and suture gad costs 500 rupees. But the rest of them are less cost prohibitive for India. So if we have to choose So we have to be very wise, and like complications are also high, maximum with GAD, because anyways you are opening 360 degrees. So the hyphema is the most common complication with any trabeculotomy, but they are self-resolving and self-limiting, and within 1 week you can get rid of the hyphema. So do we really need to open the 360 degrees trabecular meshwork? Well, I would like to say customize your mix procedure for each patient, weigh the risk and benefit, consider blood thinners, comorbid conditions, life expectancy and severity of glaucoma, and affordability, whether the patient is able to afford or not. You cannot put all the baskets in one, all the oranges in one basket. Just customize the MIGS. Be ready to face hyphema if you are if you are going to do a 360-degree trabeculotomy. And when everything fails, well, trabeculectomy still stands as a gold standard. And when trabeculectomy also fails, tubes are still there, if not anything. Thank you so much.
Thank you very much, Dr. Swati. Our next speaker is Dr. Leon Au, who comes to us from Manchester Eye Hospital in England. He did a cornea, refractive, and glaucoma surgery fellowship. He was the first to bring MIGS to England, and he'll be talking about stenting versus cutting and new technologies on the horizon.
Thanks, Steve. Thank you, Tanuj, and thank you for the Society for the invitation. And thank you for having 15 minutes to talk about devices that's been around for 15 years and all the new devices, all in 15 minutes. So apologies, of course, I'm going to bloody overrun this one. This slide is for the community, all my disclosure. But the most important disclosure for you is the fact that I am a stenter and I'm not a ripper. And I thank everybody else who has shown the slides and the talk before of all the ripping procedures and all the blood that you've seen. I don't like to see any bloods, and I'm a stenter. And I've got a good reason for it, and hopefully at the end you're going to be convinced. This is Tanuj slides. Tanuj thinks that these are all rubbish, and hopefully he'll be convinced it's not 100% true. I'm a stenter, and all we here is to restore physiology, as you know. And we all started with the Glaucoma eye stent, which seems so long ago now. And at least 15 years ago, the first device that the G1, I gather is still here. In India, they've stopped it, and I love the G1, which bypasses the meshwork, as you know. And then this is what we're trying to do. Look at the vessels inferiorly. This is the single G1 that I put in some years back, around about 2009. And all we're trying to do is to bypass the meshwork. So once you've got a G1 in, you put some vision blue in, and you can see it flow out to the vessels. You can see that we're establishing anatomical connection with collectors here. So even back then, you argue about 1 stent versus 2 stents versus 3 stents. If you're going to win the lottery, you buy more than 1 ticket. You're more likely to hit the collector channels. Then, of course, multiple stents does appear to work a bit better. So then Glasgow very quickly came out with the G2, which is the inject, which is a bit smaller, and then you get 2 goals. You get 2 opening, and you double your chances of hitting a collector channels. I love the fact that they've made it slightly bigger, which is the W, which I do like. It stops you from over-implanting a little bit. And I'm excited the fact that now we can put 3 in. You can laugh about the cost. Everything costs in life, okay? But you get 3 chances of hitting collector channels, and I'll show you a little bit about the infinite. But this is what 3 stents looks like. This is me, 3 eye stents W, 1 in the middle, and the other 2 as wide as possible. So we are going as 6 clock hours as you can, and no device that will allow you 6 clock hours of entry without ripping anything and bleeding everywhere. And then the idea is that within these 6 clock hours, you are likely to hit some collector channels. And I think we're increasing our chances of hitting the channels versus the Hydrus, which is about size. And size versus access is a battle I'm still having in my head. Watch the vessels superiorly as we irrigate. Look at that vessels gradually blanching away. We've hit collector channels up there 6 clock hours. You see the vessels just blanched away as we irrigate and remove the viscoelastic. So of course, I'm the biggest user of Vision Blue in the world, and I'm flushing the Vision Blue, and you can see how the collector channels light up 6 clock hours up there. And that's what multiple access points going to give us, multiple access to collector's channels. I don't believe you need to rip all the meshwork to hit where you need to hit. And then, of course, if you believe in size, then we have the Hydrus you hear about, that it is a bigger device. And if you think bigger is better, and not everybody can take a big device, not every vein can take a brown venflon. But if you hit the right vein with a big device, you probably get more flow. So this is a Hydrus going in, admittedly using the Glaucos gonial. It's ironic, I know. And this is the Hydrus crawling in. It takes a little bit more skill to get it in. I do not believe it's a difficult procedure. Let's not get you carried away. It's difficult to put in. But once you get it in, make sure that it's kind of inserted correctly. And then you can see the Hydrus sits in circumferentially with not a lot of it sticking out. And then you span about 2.5 clock. Watch the vessel superiorly as I pressurize the eye. Watch it, boom. You see that wave of blanching just with purely pressurizing the eye. And that's 2.5 clock hours of a Hydrus at the top. So when you hit the right canal with a big device, that's the sort of blanching you're going to get. And when you put some blue in, then you're going to see the diffuse outflow that we managed to tap into as you put the blue in. And it is quite phenomenal when you get that. I mean, this literally lights up blue everywhere. And that's quite amazing. And that's why we stent, because I still believe it's the best procedure to combine with phaco. If you come in here for a phaco, you want to see 6/6 the next day, unaided, with a toric lens implant, possibly a premium IOL, you don't really want an eye full of blood. And when you're going to cost your study, you better cost your complication too. So I still think it's the best, and we have the best data. We have the FDA trial, all of them, phaco versus phaco stent. And nothing else, no other ripping procedure has this randomized prospective trial. So you can't argue with the data that adding a device gives you extra pressure lowering. Everybody's seen the data. iStent, Hydrus give you almost up to 2 millimeters of mercury more than phaco alone. When you wash them out, you're about 20% chance more likely to get success when you put a device in. This is the official iStent inject slide, the pivotal trial, not the that's the W. So then it shows you that, again, you get a better medication reduction and you get more pressure lowering. We had it with the Hydrus, which I was part of the investigator. We ran the study for 5 years. This is the 2-year result. So you get an extra 2.3 millimeters mercury drop, and then you're about 30% more likely to be medication-free. When we ran the trial for 5 years, it is still the only mixed procedure that was powered to run for 5 years prospectively. The medication, the IOP reduction remained constant for the 5-year period. Medication-free rate was 20% more likely solidly throughout the 5 years. And this is prospective good retainment for 5 years. MIGS have no long-term data. Well, I don't think you've looked very hard. So this is from Glaucos iStents. The group of iStents that we've had, admittedly they have changed device, have had some long-term data. Previous speakers already shown. The one with the heart is mine, will sadly be beaten by Paul with his 8-year data, beat me by a year. But nonetheless, we have long-term results. The numbers of patients are small, but what you're looking at, a pressure around about 16, 17, but more importantly, once you've got a device in, we see them less often than we need to see them before the surgery. So we're now reducing post-op follow-up visit. And ultimately, MIGS has always been reducing medication can, and of course it's important to get granny off drops. This is the sort of granny with terrible red eyes that you all have in your clinic that really you don't want. Reducing medication is important. We ran the Hydrus for 5 years. We have now evidence to show you we are 3 times less likely to need subsequent glaucoma surgery when you put a device in. There's no argument about that. No one else has shown that. So you're less likely to need a trap or a tube or a diode. We have shown visual field stability. You are less likely to get worse on your visual fields if you have a device in like the Hydrus. So again, first time we've shown that rather than reducing medication, we are now affecting glaucoma outcome. iStent, this is the latest paper. They have shown the same. You look at all the phaco iStents been done, visual field has been pretty stable throughout the follow-up period compared to a normal glaucoma patient where the natural history is to get worse. New devices that may be coming through to India and other parts of the world. The Omni has been around for a little bit, certainly in the States and in Europe. So this is when you dilate the canal. We've not talked about dilation, and if you're a believer in dilation, Omni is one of the devices that you can ab-internally cannulate the canal, and you inject viscoelastic to dilate. And you can rip as well if you want to rip and see some blood. And some people just don't feel like they're finished until they have destroyed the meshwork. But this is Omni, which is an ab-internal dilation. This is the one that I prefer, which is the eye track, because we can ab-internally shoot a fiber optic with a flashing light. If you haven't seen it, it is amazing to cannulate the canal 360 degrees, that you realize this thing actually exists. It's not mythical. It does go all the way around. And this flashing light gives you confirmation you are going around, and you'll come back to see you in a minute. And then we inject viscoelastic to any degree that we like. We can inject whatever volume we like with the eye track to give you the dilation that you need. And I like the eye track because of that. Of course, now we can also make holes in the meshwork without ripping anything. So we can use an excimer laser. This is AIOS, which we have now. Excimer laser trabeculotomy, we create 10 openings in the meshwork. Each one admittedly is bigger than the eye stand if they stay open. And that is a big if, that each hole actually stay open. But this is ab-internally. You can see that we fire it at the meshwork. We make 10 openings. It's early stage. We need a lot of work to validate the opening and validate the stability and validate the results. This is the coolest thing it's going to hit. Forget cost, people. This is a 250,000 pound laser. Okay, this is the first femtosecond laser that we're going to open up your meshwork using a femtosecond without opening the eye. You come here, you lay down, I dock you, I open your meshwork, and you walk out with no steroid and no antibiotics, and you go and play golf afterwards. So this is how it's done. This is the first image-guided, OCT-guided trabeculotomy. So you lay down, you can see an intraoperative gonial. Amazing view, really. Amazing view. We have a great talk about how to put a gonial intraoperatively. You can forget about it. And then you can place your sclerotomy window anywhere you like. So we place it temporally here. You can put it anywhere you want. Any part of the angle that looks good. And then press the pedal, femtosecond do the rest. It will give you a 500 micron opening. And then you just walk out without the eye being open. So this is not surgery. This is an office-based treatment, essentially. So there's a long way to go. We're going to have to see the results. Of course, we can stick things in suprachoroidal space too. We've been there before with the SiPass. We're going there again with the MiniJet iStar. Totally different game, totally different profile. We're going into suprachoroidal space by inserting what we essentially a silicone sponge. Looks a little bit gruesome, a little bit higher potential risk profile. I've been surprised so far by how safe it actually is. It does take a bit of getting used to, and you can easily cause a big cleft or ruin the iris if you're not careful. So it demands a lot more to the surgeon. But post-op complication in terms of hyphema, pressure spike, and so forth, I'm surprised how little it has been. And in terms of the visual outcome, it has been quite good. And so I'm a little bit amazed, and I've been a little bit cautious with suprachoroidal space because of the SiPass before. But endothelial cell count seems to be okay at the moment. So we're inserting a sponge that basically with multiple holes to allow the fluid to escape. Why am I excited about the MiniJet is the fact that we're now moving into standalone procedures. We're not leaning on that phaco that Steve has mentioned that drops your pressure. We're looking at standalone. This is 3-year global MiniJet data standalone. We're dropping the IOP now by a substantial amount to around about 15 as a standalone procedure. And I think that's the big key where we're going with MIX is the fact that we're not leaning on the phaco anymore. So, and I want to show you, come back to the infinite that I told you about. We're talking standalone. This is FDA approved. Standalone study. The FDA study was in patients who's either had previous failed trap or maximum tolerable therapy. Okay, so this is what we define as refractory glaucoma. We have standalone iStent inject infinite, 3 iStent inject standalone. And that is the study that got FDA approval. We are having, again, substantial IOP lowering. But especially in the MTMT group, 8 millimeters of mercury drop as a standalone procedure. And that's quite impressive, with either the same medication or less medication than before. So we're demonstrating now substantial pressure lowering as standalone. I've got 1 minute left, and I'm going to end you with this particular one. This is what we've all been after. You get your IOP lowering, you get your medication lowering, you get your reduction in visual fields, you get your reduction in the need for glaucoma surgery. What's in it for the patient? We have the very first quality of life outcome from one of these FDA pivotal trial. And with the Hydrus as well, we did this quality of life assessment. For some reason, that never got published, so it kind of tells you something maybe. But this is one from Glaucoma. Give it credit. When you look at the quality of life outcome of the pivotal trial, people who's had an iStent with the phaco has overall a better scoring of quality of life, better scoring for the ocular surface indices. And more importantly, many aspects of the daily activity appears to be improved, but particularly interesting was the driving. They feel that they drive better, equal amount of vision, but yet by having a mixed device, they feel that the driving ability improved, possibly because of ocular surface and less medication can. So there you have it. Hopefully you are convinced that stenting is the way to go. And if you're not, you can email me and we can chat a little bit more. Thanks very much.
You make a great case for stenting versus removal of the trabecular meshwork. Our next speaker is Dr. Nikita Berry, who's our youngest speaker. She was just appointed assistant professor at the University College of Medical Science in New Delhi. And she's going to show us how aqueous angiography can help guide our MIGS. While we're waiting for the slides to go, Leon, I wanted to ask you a quick question about removal versus stenting. You know, the results of goniotomy, which is a removal, and the iStent are pretty similar. Do you think, why do you think that is, that the removal of the trabecular meshwork versus the stenting of the trabecular meshwork have similar IOP results? I mean,
if you believe the drainage, right, I mean, we've got collectors, which is, basically 1 or 2, 3 collectors along a 6 o'clock hours. So all the meshwork you remove in between the collectors is a waste of time. So you're revealing what's underneath. And if you believe that each iStent have access to a collectors, there's probably 1 or 2 clock hours either side of it. Right? I mean, it's not going to access the collectors 3 clock hours away. So if one iStent will access the collectors, there's about 1 clock hour either side of it. Then you do your maths. You put 3 in, you're going to hit something, right? So I don't really see you need to rip so much meshwork to access what's behind.
Thank you. Dr. Berry.
Good afternoon, sir. Good afternoon, respected seniors and dear friends. I would like to thank AIOC and SIR for this wonderful opportunity to present. The topic of my presentation is aqueous angiography guided minimally invasive glaucoma surgeries. We all know that aqueous flows out of the anterior chamber via either the trabecular meshwork or the uveoscleral pathway. Aqueous angiography allows us to visualize the flow of aqueous via the trabecular meshwork. So how do we perform this procedure? We take 0.1% of endocyanin green dye, which is injected in the anterior chamber, and we visualize the flow of the dye. This denotes the aqueous outflow pathways along the limbus, as you can see in the video. And in this case, we can see a 360-degree good flow that is there in this patient. So how do we capture? The machine use, no financial interest, is a flex module of the Spectralis HRA OCT, and this is how the OT setup is done. the quantitative assessment of the aqueous image, angiographic image that has been acquired is done by using the ImageJ software, and we have noted increased pixel density on the nasal quadrant, followed by the superior, inferior, and the least in the temporal one. This has been seen in most of the cases. So this is a slide to summarize the variations of aqueous outflow that we have noticed in our patients by using this technique of aqueous angiography. In the first image, we can see a 360-degree high flow region along the limbus. In the second case, we can see a segmental flow of aqueous pattern. And this is the most common pattern that has been noticed in our patients. A high flow region in the nasal quadrant and a low flow region in the temporal quadrant. And in the third image, we can see a poor flow of aqueous along the limbus. Most of the dye is in the anterior chamber itself. So why do we need aqueous angiography? What are the clinical applications of this technique in glaucoma? One, we can map the high flow region and the low flow region, which in turn can guide the choice of surgery between a MIGS versus a conventional one. It can guide the placements of stent or goniectomy incisions during the surgery. And two, it can also help us assess intraoperative functionality of MIGS. I would like to elaborate these points with the help of a few cases. So in this case, we assessed the functionality of iStent inject and performed aqueous angiography after implanting 2 iStents. So we can see in figure A, the yellow asterisks and the red asterisks are anatomically well-placed iStent inject. And we performed aqueous angiography afterwards. And in figure B, noticed a collector channel. You can see this yellow arrow, which was visible through one of the iStent, but an absence of collector channel through the other. Moving on to the other 2 cases, these 2 cases were cases of moderate POAG, one with a good aqueous outflow. We planned for a canal-based MIGS, that is bang, and the other with a poor aqueous outflow, and we planned for a conventional surgery, that is trabeculectomy. Hence, aqueous angiography aided in the decision-making between MIGS and the conventional surgery. In another case, we performed aqueous angiography and localized the high flow region to be the nasal quadrant, and we performed bang here. Our repeat aqueous angiography showed increased angiographic signal in this quadrant, suggestive of an increased flow post-bang. In another case, we identified the temporal quadrant to be the low flow region and performed bang at this place. And on repeat aqueous angiography, we noted new recruitment of aqueous channels as denoted by the green arrows. These 2 cases brings us to the burning unanswered question, whether we should place MIGS in the high flow region or in the low flow region. To answer this question, we have an ongoing study at our center, and the early results are, we performed aqueous angiography in patients of mild to moderate POAG, and in group 1, we performed bang in the high flow region, that is the nasal quadrant, and in group 2, we performed bang in the low flow region, that is the temporal quadrant, and noted the IOP at 6 months of follow-up. So the early results are that we noted a lower IOP being achieved by bang in the low flow region, that is the temporal quadrant. And at that time, please note the number of anti-glaucoma medications was similar in both the groups. So our hypothesis is that MIGS, especially bang, should be performed in the low flow region. As one, it will protect the region of the good flow from scarring, and 2, improve the outcomes of this surgery. We have noted a late closure of trabecular opening after bang. Hence, by performing bang in the temporal quadrant, we keep the area of high flow, that is usually the nasal quadrant, devoid of scarring. We have also noted a recruitment of temporal aqueous channels by performing bang there, and hence, bang in the low flow region can allow for new recruitment of channels. I completely agree that it is technically challenging at present to perform bang here, and we may think of newer procedures like Tinito and this. Another option that I can give you is that we can perform aqueous angiography, localize a low flow region in the nasal quadrant, and then perform bang. In another case, we performed aqueous angiography in a case of failed nasal bang just prior to performing trabeculectomy, and found loss of aqueous channels which were earlier present pre-bang. Hence, this encourages us to think that now we can think of performing MIGS, especially the excisional ones, in the temporal quadrant. The limitations of aqueous angiography are that it is invasive, hence a repeat aqueous angiography is difficult. It requires a sterile OT, and the machine for aqueous angiography is definitely expensive at present. I would like to summarize. The new insight of performing a bang in the temporal quadrant requires further study and validation at other centers. Aqueous angiography has opened new avenues for targeted and individualized MIGS procedure, as it can guide the choice of surgery, that is MIGS versus a conventional one, and can guide the placements of stent or goniectomy incision in the targeted high flow or low flow region. Aqueous angiography can also assess functionality of MIGS, such as iStent inject, intraoperatively. I would like to acknowledge my mentor and chief surgeon, Professor Tanuj Dada, Dr. Anand Naik Bouquet, and Dr. Ashi Gupta, and all our patients. Thank you so much.
Thank you, Nitika, for all the hard work and exceptional presentation. We now move on to one of the best anterior segment surgeons in the Asia-Pacific region, and that is none other than Shamira Pereira, who is director of the anterior segment surgery at the Singapore National Eye Center, millions of dollars in research grants and 8 patents. And he'll be covering the difficult part of today's symposium, what can go wrong with MIGS and the rescue operations. So over to you, Shamira.
This one? लगा दी HDMI.
So while we are waiting, one question for Steve. So Steve, if you have a patient with early glaucoma and cataract, so what would be your go-to procedure for cataract surgery? Would you combine with the MIGS, and if so, which MIGS?
So I'll first talk to the patient and say, do you mind being on your glaucoma medicines? If they say no, then I'll say, well, we can just do cataract alone. If they say, yeah, I'd like to try to get off 1 or 2 of the medications, and they're on a blood thinner, then I'll probably do a stenting procedure, as we just heard. If they're on no blood thinners or anything like that, then I usually do a goniotomy with a Cahoog blade.
Okay, thank you very much for the kind introduction, Tanuj, and the organizing committee for inviting me here today. Now, you've all seen some examples of excellent surgeries, but of course, there's always things that can go wrong, including my slides. Okay, advance the slides. Okay, here we go. These are my financial disclosures. Now, we all know that when something can go wrong, it probably will. And if you're not getting any complications, you're simply not doing enough surgery. I've limited my talk to basically the trabecular meshwork MIGS. This is what's being performed in India at the moment, and those cutting procedures, the stenting procedures that you're doing, I'll be going to how to deal with the problems that can occur and how to get out of a difficult situation. Generally speaking, the complications are low for all of these microinvasive glaucoma surgeries, with the numbers occurring in the few percentage points, only up to about maximum 13% in terms of PS formation. Here's one of the examples of something that can go wrong with a Hydrus device. You can see the Hydrus device going in, but what happens later on when you pull the injector out? You can see in this particular case, there's been a DM detachment. It's quite large. Often happens when you're pulling out the device. You can put air into the eye, create a bubble, leave it for 6 minutes, and then remove half the bubble, which will allow it to reform. Alongside this, there's always the worry of endothelial cell loss. And as you can see in these studies, that the CyPass was the one who had the highest amount of endothelial cell loss and led to its being withdrawn from the market. And what was happening even worse was after the 2-year time point, the amount of endothelial cell loss got worse. And that's the reason why it was removed. In most of the other MIGS, fortunately, the endothelial cell loss is very low and about 1% per year once the device is in. But of course, with the larger Hydrus, there can be difficulties with putting it in, and it may lead to an increased cell loss at the initial stages. Here's an example of a diving hydrus. You can see it's going down into the area behind the iris and it's lost. So you have to withdraw this. You can't leave it in that position. It might cause problems with UGH syndrome, but also with removing it, you can cause a cleft or even an iridodysis. So you just remove it back as you put it in, and you can move around a few clock hours and then reinsert it. Here's another example of one of the complications that occur with a hydrus, which is an in and out hydrus. And you can see it's gone in but out. This is actually a left-handed surgeon putting it in, and it's gone in but come out. And this often happens when you've got the eye over-inflated, so the trabecular meshwork is pushed together. So it goes in but also comes out. Also, you can imagine in eyes where there's an extreme myope, the curvature is not quite right. And you can see here the curvature doesn't match up. So again, this nitinol-based device doesn't expand or contract very easily with changes in curvature, and this can lead to problems with this in and out. This is a complication of mine. During a hydrus insertion, I managed to rip off 40% of the iris. You can see a massive 40% iridodysis here. The patient was moving as a patient with learning difficulties and Tourette's, and you can see even the difficulties I'm having putting this iris back together again using 3 Hoffman pockets and a tenoproline needle, grasping the edge of the iris and reinserting it back to where it should be. You can allow it to hang back, but of course, the difficulties I'm having here with this moving patient put me through a lot of stress. But in the end, you can see it does actually look quite reasonable at the end with a round pupil. But of course, I've not put the hydrus in, I've taken it out, and I need another glaucoma surgery like a tube later on. Another one of the difficulties you can have with complications is the formation of PAS. And you can see the occlusion rates of G1 are very low in the POAG eyes, but in PACG can go up very massively. Interestingly, the results of hydrus in PACG are actually very similar to POAG, and there's an example here of me putting a hydrus in behind where the PAS is here, in the only one quadrant where it's able to put it in. I then, once popping it into the right position, I'm able to peel down the PAS here, revealing the device in the angle. In the end, the patient did well, but is it because of the phaco, is it because of the hydrus, or is it because of the GSL? No one knows. Again, be careful with these situations because the reoccurrence of PAS is still very, very high. And if the PAS comes up to your inlet for the hydrus, it leads to a larger spike in IOP rather than if it comes up to the 3 windows. These are some things that can go wrong. You can see the DM detachments, diving hydrus, and iris to the windows that can occur. Here's an example of an eye stent in too much of a superficial insertion. Here you can just flip it out with the trocar and reinsert it by threading it back in again. But of course, remember, you've only got 2 stents and 4 shots with this, so you have to be judicious with the amount of shots that you use. Once you've got it reinserted, back in the needle, you can do that, by the way, inside the eye or outside the eye. I actually prefer doing it outside the eye and then reinsert it a few clock hours down the line. So it is definitely possible to do this, and especially with the iStent Infinite, which you've got right now, when you've got infinite number of shots, we should actually be putting it into the best position. And if it's not quite right, the onus is on us to remove it and put it in correctly. Here, there's quite a lot of striae being formed, but it goes in a nice position there. Here's some examples of what can go wrong with some of the eye stents. Here's a very shaky surgeon here, but of course, once you pop it into the right position and withdraw straight out, actually it looks quite decent. Moving across 2 clock hours, they're much more confident for their second insertion, and it goes in. And then when they come out, as long as you come out in a perpendicular fashion, it looks quite nice. Now, this example of something called needle bias or sideways tilt. You can see the needle just in the groove, the cutout, and it's being pulled to one side. So you've got to be careful with that because the stent doesn't go in easily. This one's over-inserted. And even this one, you can see the needle is bending as the inserter is being pulled to one side and the other. Fortunately, this one goes in okay. There's a plume of blood. Here again is an over-insertion. This is because you can't really see the area very well, and there's striae on the cornea, and there's no good en-face maneuver here, so you can see the stent is going in too far. This has largely been alleviated by the new versions of the iStent with the iStent G2W. You can see these examples of a good iStent G1 inserted in the canal on the AIOS, but also some poorly malpositioned ones with the G2 here above and below and inserted too far in as well. The improvements in design have led to a wider stent and a wider flange, so that means it's harder for it to get over-inserted. And even the materials are better now with less trocar bias available, and the materials are much stronger, so it stays steady when you put it in. Here's an example of a good G2W with reflux, showing you that it's harder to get that over-insertion. Here one goes in quite nicely, and the neck of the device is in the canal. And a nice wide flange this time outside. You can see some blood refluxing outwards as well. This is one of the most dramatic complications that you can get with a eye stent. It's called pinball wizard. One stent goes in quite nicely. Second one is definitely under-inserted, and you can see that there's too much coming out. And when you do the IA, it starts to pull out a little bit. See it moving? And then in the end, it comes out completely and shoots around in slow motion around the anterior chamber. Eventually settles on the iris. You can pick it up with a micro forceps, rethread it, and put it back in again. So here I am removing it and rethreading it outside the eye. Actually does go in quite nicely in the end, reinserted. Whilst much has been made of the complications that can occur with the large stripping procedures, many people never have seen something as large as this. This is a post-op high femur occurring in a KDB eye. You can see there's an endocapsular high femur. And actually, this is a testament to the fact that actually it does work, that the blood drained from in front, but didn't drain from the back after a long time. I didn't yag this, I left it alone, it did go away by itself. Here's iridialysis occurring with the KDB. And you can see when the KDB is being used to the side, it's off the screen, you notice to keep your devices in view. And here you can't see what's going on. And when the surgeon comes out, they can see they've actually caused a small sarcoidosis cleft. You'll see that when they do the IA. But in this case, it was quite small. Can you see here? Maybe 1 and 2 clock hours. It's okay to leave it. It's not going to cause much problems. But you can see the nice cleft that's been formed, the removal of tissue in the goniectomy by the KDB. Some of the other complications that can occur with GAT, of course, are high femur. This unusual complication where there's a leakage of blood if you stand on your head or you valsalva, and the blood can come out from the canal into the AC, causing intermittent blurring of vision. Fortunately, the complications after trabectome are also similar to those after some of the other MIGS procedures. Of course, with GAT, the limitation is, of course, the formation of PAS in the longer term. It's quite a destructive procedure, and the high femur that occurs is pro-inflammatory, and also you end up with these small PS, which it ultimately limits the efficacy of the procedure. So in general, it's very important that you're listening to this and learning the ways of dealing with complications, because you will find them if you do enough surgeries. The learning curve for TM MIGS is transferable. So actually, when you learn the procedures to deal with these complications, let's say being even putting an air bubble in, or repairing a sarcoidosis cleft, or a iridodialysis, they can be used in your other surgeries as well. I think the most important thing to say is these are taken from over 1,000 different surgeries, and I think that generally speaking, these devices are very safe. But it is important to be able to deal with the upcoming complications that can occur and to set the patient's expectations correctly. I've tried all the ways of creating shortcuts with these MIGS, and the one thing I've learned is you must stick to the rules on this. So thank you very much for your attention. Hope you don't have any nightmares.
Thank you, Shamira. That was quite a scary presentation. Thanks for the warning. And our next speaker, it's very difficult to introduce Dr. Andrew Mahmood. In short, I would say he's the first glaucoma billionaire of the world. And the best part is that he has pledged his entire wealth for humanitarian service. And you'll be very surprised to know he runs several schools and hospitals in India. And when the last time he visited India, so I asked him, why are you coming? So he said, my daughter is getting married. So this was a school in South India where he had funded, and this orphan girl whose Andrew has brought up, and when she got to marriageable age, so it was Andrew who gave away that child as a father. And so it was very moving for me, all the way from Switzerland, and so much of the service he has done. He is, of course, professor at the famous Jules Gonin Eye Hospital. He's the father of non-penetrating glaucoma surgery. He's invented the AIOS implant and trained many fellows, one of the finest surgeons. And I thought there is no symposium MIGS till you have words of wisdom from Andre. So the topic is MIGS versus MEGS, and MEGS means minimally effective glaucoma surgery. So over to you, Andre.
Thank you very much, Tanuj, first for the invitation to be part of this fantastic meeting, and thank you for the kind words of introduction. My main practice is to treat very advanced glaucoma, because in Switzerland, my colleagues send me the very difficult case, and often when they failed mixed surgery or other kind of surgery, those patients will come to me. And that's why I don't personally do very many MIGS, because my patients are not, MIGS candidates. The same as Tanuj said, I'm working half of my time in Africa, where I'm operating a lot of patients, and I can tell you in Africa, it's probably like in a rural area in India, patients don't have much money, patients don't come for follow-ups, and I don't think that MIGS is a good solution for this kind of population. But anyway, I'm going to speak about MIGS. A lot of it has been said already by my colleagues here, and first of all, I want to dedicate this lecture to my very good friend and mentor, Ravi Thomas. I used to work with him. I was a visiting professor in Vellore in 1994. And then I also visited Ravi Thomas many times in LV Prasad when he was over there. Now, the MIGS, I don't want to repeat what my colleagues said before, but you can do so many kind of MIGS. They can be in the angle, they can be in the suprachoroidal space, they can be under the conjunctiva. I'm going to just give you a few words. This is my friend Aike Ahmed. And his ideal glaucoma surgery was to have a pressure of 10 millimeters of mercury, taking just 10 minutes, and which will work for 10 years. So MIGS for minimally invasive glaucoma surgery means, if possible, ab interno approach that is minimally traumatic, at least modest efficacy that is sustained, extremely high safety profile, and rapid recovery with minimal impact of quality of life. This was Aike's words. And if you look at that slide, these are all the MIGS you can find on the market today, and there are so many. They can be either subconjunctival, as I said, trabecular drainage, suprachoroidal, or cyclodestructive procedures. I'm going to just show you a few slides on the results of the most used MIGS today in the world. The Kauk blades, and we saw many beautiful videos, is, as it was said, to rip the trabeculum and to re-establish a good path between the anterior chamber and the collector channels. This is OCT seeing that the Schlemm's canal has been open, and the results are quite good. But if you look carefully at the slide, the mean pressure is about 15 to 16 after 6 months. And if you wait longer, it's about, basically the pressure will be about 15. With not very much complication, as you can see on the right side, a few IOSP spike, a few bleedings, but that's not bad. So the overall reduction is 36%, which is okay if the pressure is 18. But if the preoperative pressure is 35, what we often see in very advanced glaucoma, that won't be probably sufficient. The eye stent is very easy to do. You usually do it after cataract surgery, and then you just plug in those 2 plugs or 3 plugs today. It has been, as it was said, it's functioning quite well. As you can see here, it's easy to do. And it's interesting to see those the OCT done by Gilman, one of my fellow, showing that you have an enlargement. If you look on the opposite side, the Schlemm's canal is very small. If you look at the place where the eye stent was placed, you have an enlargement of the size of your Schlemm's canal. So there is efficacy. And in terms of IOP reduction, we got minus 9% of IOP. We could reduce the medication by 72%. So it's very useful if you have early glaucoma and you want to reduce the medical treatment. Interestingly, you can see that if you do post-op anterior chamber angiography, and this was done by our colleague Wang in San Diego, you can see that there is an increase of outflow in the site of your eye stent implantation. The iris, you saw beautiful videos from my colleagues also. It's not as easy to perform as the eye stent, but it's quite easy, and usually we do it after cataract surgery when patients have intolerance of glaucoma medication or slightly higher pressure like 22, 23 in early glaucoma. That's when I sometimes use the iris stent, and the results I'm not going to stay here because you already see so many videos. And I'm going to just give you a few results of the Horizon study, which is a very interesting study because it's a large study, prospective, multi-center, single mask, randomized study, which was done in 556 patients. 1/3 was just phaco alone as the comparative group, and 369 patients had phaco plus iris. So iris was, of course, in every case put correctly, and these are the pressure in the post-op period of 24 months. You can see that the reduction in pressure is about 20%. And this slide is more interesting because you can see that if the blue lines are the reduction of the combined, and then the gray line is just the phaco. And the difference between phaco without iris and the phaco with iris is about 20%. An example, if the pre-op pressure is 20, then it will reach 16. If the pre-op pressure is 25, it will reach 20. And if the pre-op pressure is 30, it will reach 24. And this, for me, is not enough for a patient with advanced glaucoma where the aimed pressure is 10 to 12. Of course, if it's very early glaucoma, you can actually play with these devices. Now, the mini-eject is something new. It will create cyclodialysis and bring the aqueous into the subchoroidal space. And it's a very interesting, promising device. It's quite new. And you saw a beautiful video from Leon, so I'm not going to show you this one because it's not as nice as your Leon. Your video was much better. You picked the best. But I mean, you have to go at the root of the iris, and then you stick in this implant. You can see it here very nicely on OCT of the anterior segment. And now I'm going to the GEN. Nobody spoke about the subconjunctival mini-invasive surgery, and the XEN gel has been widely used in the last almost 10 years. So I'm just going to show you now maybe a video. It's the Pozoy law, which is actually used in this principle. You have a 6 millimeters long tube with a 45 to 60 micron diameter inside diameter. And this goes from the anterior chamber to the subconjunctival space. So this is how you use it. You fill the chamber with viscoelastic. I do a second paracentesis to be able to hold the eye down. I'm injecting mitomycin in the upper quadrant. I'm checking that the XEN is in the deliver system, and then I will put the needle in the angle, aim 3 millimeters posterior to the limbus and come out under the conjunctiva, and then inject the XEN device. Okay? What are the results? Well, my colleague Mansouri has analyzed our results on 129 eyes. Here is the pressure. We had a very small group of Xen alone, which is in dark, and then Xen plus cataract, which is the light line, which shows nice results, but mean pressure after 2 years of 14 millimeters of mercury. And this is it's a good result, but it's not, to me, enough for advanced glaucoma. Adverse events were not so many. A few ifema, very few choroidal detachment and hypotony. So this is quite safe surgery. It's easy surgery to do. As you saw, it takes about 5 minutes. The operation rate is 10%. And one problem is that it will create a very thin, usually quite avascular bleb, as you can see, and then the rate of needling is quite high. Almost 50% of your patient will need a needling after some time. This is 26% at 1 needling, 12% at 2 needling, and 7% at 3 needlings. The blebs don't often look nice, and when you have to reoperate those patients, then it's quite difficult because the conjunctiva is very thin, it's very fragile, and it's very difficult to redo a filtering surgery if you have this kind of condition. Now, more recently, you have the preserved flow, which is almost like a trabeculectomy, but you don't need to open the chamber. The tube will actually replace the flap and replace the trabeculectomy itself. The results are quite good. They basically show the same results as a trabeculectomy. But the surgery needs also to open the conj and then to close the conj. So it's not a big difference. It's really just an easy surgery. I'm not sure that it's really a MIGS. So to summarize, MIGS complications are often lower in comparison with classic filtering surgery such as trabeculectomy or deep sclerectomy. Angular MIGS are more effective in early glaucoma when the downstream system is healthy. Suprachoroidal MIGS and subconjunctival MIGS use other drainage pathway, but the final IOP is in the middle teens, meaning 15, 16s. I normally do deep sclerectomy, which has not many complications and actually has the same low complication as most of the MIGS. And then, in some cases, MIGS might be a good option. As I said, if you have very early glaucoma, if you want to reduce the treatment, the medical treatment, if the patient don't want a major surgery, it's a good option. Sometimes it's not a good option because the results, as you saw this morning, are not optimal when we want to have very low pressure. And this is most of our very advanced glaucoma cases. They need very low pressure. Then MIGS, I don't think it's a good option. And so if I come back to Ike Ahmed's slide, MIGS, are they really ideal glaucoma surgery? Are they bringing the pressure to 10 millimeters? No. Is it a 10-minute surgery? Yes. Will it stay for 10 years? I don't know. Probably not. So don't forget that MIGS also have a price, and compared to standard surgery, they will cost much more money. In Switzerland, all our MIGS cost between 1,000 and 2,000 Swiss francs, which is about 1 lakh to 2 lakhs Indian rupee. And this doesn't include the surgery cost. That's just to buy the device. So it is definitely expensive, and especially if you are working in rural areas where patients can't afford this kind of surgery. Thank you very much for your attention.
So thank you, Andrew. So I think we have had a lot of interesting talks, and just one or 2 points I want to bring across. Like in trabeculectomy, we use mitomycin C to prevent fibrosis. So there is no anti-fibrotic agent available for MIGS. So whenever we do any sort of canal surgery, even you put a stent, there is bound to be a fibrotic reaction. and over time you may get a rebound increase in intraocular pressure. So whenever you do a mix, you have to warn the patient that this will not be the final procedure. He may require a subsequent surgery to lower the IOP because this has a lifespan. It is not going to work for say 5 to 10 years. And the second issue is, I think it may not be prudent to operate 360 degree of the canal, because most of the studies show that the complications go very high when you operate 360. So operating on 90 to 120 degree is a good optimal range where you decrease complications and you increase efficacy. And I think important for us is that everybody has his own favorite MIGS. So you have to, all of us have to learn MIGS, have to learn gonioscopy, and whatever you're comfortable with, that you should perform. Don't go with either iStent or Hydrus or any of the expensive devices. For developing countries like India, any of the canal-based surgery which you can do free of cost with a 26-gauge needle are also quite efficacious. You don't need to push the patients to buy an expensive implant. So if there are any questions from the audience, we'll be happy to take them. And Steve, you have any questions for the panel?
No, I think it was pretty interesting that all of us pretty much said the same thing, but in a different way. All talked about the same, I think we had 6 different MIGs talked about today, and we all said about the same thing, that the results are pretty similar, but we had some pretty strong opinions about whether or not, whether you should stent it or whether you should remove it. I guess I was just going to ask our panelists, because, between the group of us, there's probably 1,000 or 10,000 cases. Is there any way to predict which, we talked about angiography, but we saw in even the angiography, there were some patients who you put in the high flow systems and the low flow systems, they didn't do well. Does anybody have any idea about which patients do better with MIGS, or any ideas about, why a MIGS might have worked in this person versus not, or why in this same person's one eye it worked and the other eye it didn't?
Yeah, Shamira, you go first.
Okay, so it's actually very difficult to go and to tell the difference. And I think we've got some evidence from things like, for example, the water drinking test. I think that would be quite interesting to see what happens with that. I think in general, in terms of the actual placement of the MIGS in a particular eye, I think there are certain things that you can look at when you do that for placement. I would rather go for areas where there's pigment rather than where the TM peters out and it's white. I'd like to see a nice canal full of blood. That's another nice thing. And not one where there's like straggly areas. We've put devices and cameras around that area so you can see what happens to the canal. And there's often areas where it's clogged up and you can't put your, let's say, your suture through. There are the very obvious ones where we shouldn't be doing MIGS in. For example, those with high episcleral venous pressure. So those with things like Sturge-Weber syndrome. And the fact is that we don't know what the episcleral venous plexus is like. People say that, if you expand it with viscoelastic, it might keep it open, but it's hard to imagine that lasting for the longer term as well. With these videos we've seen with the angiography, when we're introducing that at high pressure, that's not the same as what will happen at normal pressures. So just because, you see good flow, blanching at very high pressures, that may not work at normal pressures. And I think that's the kind of difficulties that we have with working out, not just with which patient to put MIGS in, but also where to put it in.
No, you make a great point. The angiography studies by Alex, showed that he did it before the surgery and after his surgery. He also did it like 5 minutes later, and different things opened up at different times. So it was quite variable, the angiography flow at the meshwork. You did mention about pigment, that you like to go for areas of pigment. Can you just say a little bit of why? Is that because those are areas of high flow or low flow, or?
I think the areas of pigment are areas where there has been some flow before. I think that's the way I'll put it. And we've seen it when we put in Hydrus devices where somebody's gone for an area of white and it's hard to go and push in. And then they move along a little bit and where's pigment and it actually goes in quite nicely.
Great. So Leon, one question for you, because you showed the dye injection and you studied the flow. So would it be good to introduce one iStent and then do the flow and then put the second iStent? Because how do you know if one is not conducting the fluid?
You're correct, and I did that actually. I teed up a Saturday list, so there's no training. I had all the time. I decided I want to put one eye stent to the dye, put a second to the dye, and did a third to the dye. Told the nurse it's going to take 2 hours. Pick the patient with the best endothelial cell count. After you put one eye stent in, you get a lovely dye out of the eye stent. I was excited. And you turn the patient back in, put the Helon GV back in, and your view's gone. It's vision blue everywhere. And then the view was rubbish. So then actually it's quite a struggle. And I think I take the point, the fact that the dye goes out at high pressure. So it's not physiological, but at least it's anatomical. And I think that's something. And even then, your dye test, like Alex has shown that the canal opens and closes, and it's fascinating, the whole drainage system. I think we understand so little of it. But nowadays, if I do put some vision blue in, and genuinely, if my eye stent is not flowing, I would seriously consider moving it, and it'll be very hard for me to move a hydrus. So I think that is the argument between those two for me. And you're very correct, Steve, that it can be a bit hit and miss. And I don't, I'm not so sure I can predict it, apart from the fact that you pick your mild and moderate patients. And which then goes back to this cheeky argument about ripping, is the fact that I will hate it when I rip it and you've got an eye full of blood for 2 weeks and it still didn't work. That's disheartening for me.
We only have a few more minutes left, but I was, Dr. Merbert, we didn't have anything that was that met the 10-10-10, at least, and none of the MIGs do. So in your experience, which is your kind of go-to surgery for the 10-10-10?
Well, in my daily practice, I'll perform deep sclerectomy, but it doesn't meet the 10 minutes, I must say. It takes about, if the case is very easy and everything goes well, and the scrubbing nurse is nice and everything, it may take 20 minutes.
Andre, I don't think that is true. We watched your live surgery at Switzerland. Honestly, it was 10 minutes, and then it was done. It was ridiculous.
But the 10 millimeters of mercury is reached, definitely. And the 10 years is reached because my first case I did exactly 30 years ago and is still functioning. But I mean, not every case, I must say, because glaucoma surgery is never 100% successful.
So you're choosing deep sclerectomy even instead of the Zen stent for most of your patients, right? Because the pressure lowering is better and et cetera.
Yes. The Zen, I'm not so happy. I mean, I did many at the beginning because I had some hope that it will solve the problems for the 10 minutes. But then the results are not so good in terms of the blebs, the needling, the need of needling is very high. And then when you have to reoperate, then you're in a big mess because the conjunctiva is very ischemic and difficult to handle. Just a little funny thing, or I don't know if it's funny, but Switzerland being probably one of the richest countries on earth. So there is a lot of money for everything. But interestingly, the insurances and the government actually doesn't pay anymore for the MIGs since the 1st of January. And so now we're not allowed to put MIGs anymore in Switzerland because it's too expensive and not efficient enough. That's the government decision.
Yeah. Thank you. And just one more point. It's good to combine two MIGS procedures. So if you can dilate the canal and then do your cutting procedure or stenting, it may be better. And at RP Center, what we did a simple modification. We now use a 30-gauge needle during bang and connect it to the Helon cannula. So first we inject Helon into the canal to balloon the canal, and then we cut the canal. So advantage is you're getting viscodilatation. And second thing is, in any of the cutting procedures, you need to prevent damage to the posterior wall of the canal. So if you inject viscoelastic into the canal, that is the additional advantage you can get. So any views on Leon dilating the canal and then stenting?
Tanuja, what's the point of you dilating it when you're going to rip it? What's the point of dilating the canal when you're going to rip it?
So two things. One is, you are dilating in a circumference which is additional to cutting. So we are cutting only 30 degrees at our...
Or you do a 360 dilation.
So dilatation will be just adjacent to those 30 degrees. So it may be about 90 degrees. Second is, when you are putting these needles, 26 gauge or 30 gauge, there's a chance of hitting the posterior wall. So that leads to bleeding, and that also incites scarring cycle. So I think it's good to put in a viscoelastic and then cut. So you have a balloon canal. So I think we have just reached 1 o'clock. So we have had a wonderful MIGA session. I thank the wonderful audience for their patience sitting through this 2 hours of grueling MIGA symposium. And I am fully my humble gratitude to all the speakers for their very excellent talks. And I'm very glad that some of the young speakers from India have done so much studies and are doing well with MIGS. And I thank Leon and Steven, Shamira, and Andrew for coming such a long way to discuss their experience about MIGS. So I'm very grateful. Thank you very much. So we'll have 1 hour break for lunch. And those who survive lunch can come back at 2 o'clock.